All right, going to the other end of the pendulum, not the table pendulum, the spectrum of symptoms, IBS-C. We have a lot of products that are FDA approved for IBS with constipation. Why not just use over-the-counter laxatives? They're there. And is that what people are doing anyway? So can you talk about just what we got on the market on laxatives and what the approach is using just Miralax, or not to use a brand, but something that just makes the stool moist?
Yeah, so there is no shortage of over-the-counter laxatives that are out there. That a lot of times, patients, by the time that they come to your office, they've tried multiple one of them. On average, patients have tried 5 medications before, over-the-counter medications before they come to you. The most common ones include the herbal laxatives, such as Senecot. There is Ayurvedic even medications that are becoming very common, like Triphala. There are supplements such as magnesium supplements that can be used, and also there are Miralax type drugs, whether the generic form or Miralax, which is very safe, and we use it very commonly for constipation and also for colonoscopy preparation at larger doses. So it has a very large therapeutic window. So it's quite safe and it's non-absorbable. And also there are stool softeners as well. But again, for somebody with mild symptoms, can we use these to help with their symptoms? Absolutely. If that helps their symptoms and controls what bothers them, that's definitely a way to go. And you don't need necessarily to go to the big guns that are now being approved.
We're going to, okay, go ahead.
Well, I think it's worth also mentioning that there is one study with polyethylene glycol was done in Europe. It had electrolytes, but essentially the same product that showed that it didn't improve abdominal pain. So like Ali said, it's quite effective at improving bowel function, but it doesn't seem to help pain. But it's still my first go-to treatment for someone with IBS, with constipation, and I agree. The nice thing about polyethylene glycol is that you can titrate the dose. And what I'll tell my patients is that, you've got to give this 4 to 6 or 8 weeks where you're playing with the dose, not every day, but every 4 or 5 or every week to make it easier for patients to find the point where your stools are soft, not loose, but soft, and give it time. That won't, don't expect it to improve all of your symptoms, but see if that's enough for you. Because those patients, like Ali said, that are mild, that may be sufficient for them, and they may be quite happy. I personally combine it with fiber. And so I will give them a variety of different types of fiber, and that's what takes the 6 to 8 weeks, is to find that right combination that they think is best for them. And we use different types of fiber. Personally use prunes, but may also use psyllium-based products as well. There's a whole bunch of different types of fibers. I use the combinations. So your question was the bigger guns?
Oh no, I'm not there yet, but I'm just surprised I used the word moist to make on stools. So maybe we're moving to the moisturizers, otherwise known as secretagogues. Bill's looking at me like, don't use moisturizers. But first out of the gate, Lubiprostone. You were involved heavily in some of that work, Bill, and can you just start us off with the moisturizers or secretagogues here, Lubiprostone?
Sure. So Lubiprostone acts directly on the CLC2 channel, which is an important chloride channel on the apical surface of the enterocyte. So it acts predominantly in the small intestine to increase chloride secretion, and that negatively charged chloride leads to paracellular movement of sodium and water, which you can imagine helps with stool consistency and increasing the mass of stool, which can stimulate peristalsis. So Lubiprostone has been shown to be of benefit to constipation, and there are 2 doses that are available in the United States. There's a 24 microgram dose given twice a day for chronic idiopathic constipation, and an 8 microgram dose given twice a day for IBS-C. The big issue to be aware of, outside of the fact that it seems to improve, by the way, the constipation symptoms and the abdominal symptoms, is the fact that there's dose-dependent nausea. So with the higher dose of Lubiprostone, in the clinical trials, 29% of patients developed some degree of nausea, most of it mild, but there's the occasional patient that can get significant nausea, and people should just remember you should give this drug with food to try to minimize the likelihood of developing nausea.
It's transient, though,
Yeah.
in general. Yeah.
So anybody else on the panel uses lubiprostone often? Brennan, do you use that in your practice?
You know, not very much anymore, because there's been so many other medicines to come along since then that, in my experience, are equally or more effective with better tolerance. But I do want to make the point more generally, as we just discuss IBS-C management, that it is important for the viewers to distinguish chronic constipation from IBS with constipation. I don't think we've made that point explicit just yet, now that we've shifted to the pendulum, as you say. You know, constipation and IBS with constipation obviously both have constipation, but what distinguishes them is the abdominal symptoms. You know, the pain, the discomfort, the sensory experience, the bloating. And it's not like these are two completely different conditions. There's a bit of a spectrum, you know, as people get more or less abdominal pain. I think it's important because some of the treatments we're talking about, you know, like laxatives, might do a really good job at the constipation, but might not improve the symptoms of abdominal pain or discomfort. So as we go through these different treatments, I think about some of them as really just bowel treatments, and others as multi-symptom, you know, targeting the multiple symptoms of IBS-C. And lubiprostone is an example that does really hit multiple symptoms based upon the clinical trials, and it's the first of a few that we'll talk about here that I think are able to do that.